Hi everyone, I'm Jeevan, a radiologist from St. Michael's Hospital, Toronto, and this is T1 and T2 mapping where the rubber meets the road. This is a practical talk on tissue mapping, a how we do it roadmap on how to get tissue mapping off the ground at your hospital, and it will be most applicable to you if you're new to tissue mapping. Well, today we'll talk about what it is, how to pay for it, how to prepare for it, and how to acquire it with clinical cases along the way to illustrate how to report and avoid pitfalls. T1 mapping measures the longitudinal or spin lattice relaxation time determined by how quickly protons re-equilibrate their spins or recover longitudinal magnetization after RF excitation. Obviously, different pathologies affect myocardial T1 in different ways. T1 mapping is a sophisticated way of detecting myocardial pathology before it manifests on our previous methods of myocardial characterization, for example, late gadolinium enhancement, and also potentially tease out what that abnormality might be. The black line represents normal. Water, fibrosis, inflammation, and amyloid infiltration all increase native T1, while fat and iron decrease it. The extracellular volume fraction, or ECV, is calculated using this equation here. So if you have pre- and post-contrast T1 maps and the patient's hematocrit, you can calculate the ECV. The extracellular space is what holds on to gadolinium on late gadolinium enhancement sequences. Various pathologies affect the extracellular space to different degrees. The greater this is, the higher the ECV fraction gets. T2 mapping is a time constant representing the decay of transverse magnetization. T2 maps depict the spin-spin or transverse relaxation of myocardium and detect myocardial edema. A practical example of how it can be useful is to determine if an elevated T1 value is due to edema or inflammation which elevate T2, or things like fibrosis or amyloid infiltration which generally do not elevate T2. At St. Michael's Hospital, we've been doing cardiac tissue mapping with T1, ECV, and T2 since May 2017. We have a large pool of technologists with varying teachability and skill level who are under constant time pressure, and a small physician team, therefore most scans are not MD supervised. Cardiac imaging takes up just 3% of magnet time. We have 4 magnets, 2 Philips Achivas, and 2 Siemens Vitas, and we have tissue mapping on all magnets. The sequences, if you don't already have them, cost the price of a small sports car. One way of paying for them is to share costs between radiology and cardiology. Or if one of your patrons is a philanthropist with deep pockets, maybe he can cough up some spare change. Or you could try bundling into a larger expense, like a scanner purchase, a scanner refurbishment, or a scanner upgrade. And we chose this one when we got started with tissue mapping initially. Before you start tissue mapping, it's a good idea to get some teaching out of the way, some didactic lectures, a lunch and learn, hand out some guideline and review articles, introduce people to the free CMR Pocket Guide. And your vendor application specialist will likely pay you a visit so your techs know what they're doing before they start clinically. What we didn't want to do was further lengthen what is already a long scan by simply adding sequences and scan time to existing protocols. So we went to work reviewing our existing protocols to see where we could save time. We used updated sequences with better acceleration and reduced the resolution of our SSFP slightly, which allowed us to save time on city imaging. And we cut some of our late gadolinium enhancement sequences, which we felt at the time we could do without. Eventually, even adding the tissue mapping sequences in, we ended up with the shortest scan time that we initially started out with. To calculate ECV, you're going to need to get an hematocrit, which means getting a CBC. One option is to get the technologist to draw, label, and send blood off to the lab, which may not be met with praise. Sending your patient to a hospital lab or to an outside lab if scanned outside core hours or on weekends is an option. SCMR allows you to get the sample up to 24 hours outside of beyond the scan acquisition time. And inpatients usually get their bloods performed by the referring team. Some centers use a point-of-care device, and some people use a synthetic hematocrit. We decided to do a combination of these 3 options. If you order blood tests, you will get blood results. Some of them are going to be abnormal, and it's important to look through the results and send these on to the referring clinician. All tissue mapping data can be presented in numeric terms by the use of regions of interest or ROIs. But assigning colors to the values allows maps to rapidly communicate more information, like these beautiful cold to hot color spectrum lookup tables presented by Martin Ugander at SCMR 2014. These two we really liked and decided to adopt into our practice. So you can see we've created another color spectrum on T1, ECV. And if you look at our T1 maps, normal looks like this. It's sort of greenish yellow, and ECV looks like this, which is blue when in a normal patient. Why use a color map? Why not just drop multiple regions of interest all over the left ventricle? Because it's sort of like looking for treasure without a map, like this movie Holes, which starred Shia LaBeouf, where he and a bunch of friends had to dig up an entire desert looking for the treasure. So what you can do is if you overlay a color lookup table, you add color to your map, and suddenly you can see all the abnormalities, which, as long as you have color vision, gives this very powerful quantitative tool a qualitative overlay, allowing you to rapidly assess all the myocardium you see. In this acute myocardial infarct, there's an acute infarct with the core over here. There is a penumbra of area at risk, which is edematous. And within the core of the infarct, there's also this area with low T2 signal. This is because the patient's had intramyocardial hemorrhage and the iron is reducing the T2 relaxation values. So now you're behaving more like a pirate with a map. You're able to go directly to the buried treasure and dig it up. Not only can the information be displayed on the image in color using lookup tables and the color scale, it can also be displayed graphically with a bullseye plot. For example, in this patient with apical HCM and subtle apical scar, we can see as we go from base to apex, our T1 values start to go up, as well as our ECV. These 5 protocols comprise 2/3 of all the CMR we acquire: delayed enhancement, amyloid, ARVC, HCM, and myocarditis. Most of them have 3 T1 and T2 maps, pre and post contrast, and we also acquire 3 T2 maps for these 3 protocols here. For HCM, we also acquire 1 vertical long axis T1 map so that we can see the apex more clearly, especially in hypertrophied apices where you may not get the blood pool on your apical slice. And the true apex is also visible on this long axis view. In myocarditis, we cover the entire LV with 7 short axis T2 maps. Here's a clinical case, a patient with acute myocarditis with high signal intensity, subepicardial late gadolinium enhancement with corresponding elevated T1, ECV, and low T1 on the post-contrast T1 map. On the T2 map, we can see that there's diffuse T2 elevation. Sorry, there's T2 elevation, not diffusely, sorry, in the infralateral wall. Here's a patient who had post-vaccine myocarditis, and similarly, you can see late gadolinium enhancement, edema corresponding to that, telling us that this is acute or subacute. There's elevated native T1 and ECV in the affected regions. Similar story here, another patient with vaccine-induced myocarditis with multiple foci of edema corresponding to the late gadolinium enhancement that we can see. If your scanner produces motion-corrected maps, that's wonderful. That will give you something really easy to contour and to get your data from. If not, you can use third-party software to motion-correct the raw images from the MOLI sequence and create your own motion-corrected image. What can you expect to encounter with T1 mapping? Well, we can see at the lower end of the spectrum, things like hemochromatosis, and iron obviously decreasing the native T1. Intramyocardial fat due to an old infarct, which has undergone fatty metaplasia, will show up with this blue color here. More diffuse T1 reduction in a case with Anderson-Fabry disease because of lipid accumulation. Here's our normal range between 942 and 1074. Here's a patient with Takotsubo cardiomyopathy with elevated T1 values in the apex. Someone with dilated cardiomyopathy, higher T1 values in the interventricular septum than in the lateral wall. A patient with myocarditis with infralateral wall T1 elevation. A patient with amyloid with diffuse T1 elevation. And finally, a patient with an LAD infarct at the apex. Tissue mapping does not bring much added value to cases like this, where there's always Oreo cookie sign late GAD, which is, of course, an adverse prognostic indicator. It's also not as helpful in cases like this, where there's obvious midwall scar because of potential infiltrative disease. But it is useful in cases like this, where there is no late gadolinium enhancement to be found, but we can see that native T1 is elevated in the septum, higher than the lateral wall, and ECV is also elevated. So we can detect early non-ischemic scar. And we can do this even in patients like this hemodialysis patient back at a time when we didn't used to give gadolinium to hemodialysis patients. We can do this even without contrast. Here's normal T2 map and elevated T1 in the interventricular septum, confirming early non-ischemic scar without any contrast. Researchers have also found that both T1 and ECV are able to risk stratify DCM patients without evidence of coronary artery disease in whom there is no late gadolinium enhancement. You can see these two groups here with patients with higher T1 values having a divergent survival curve that is worse than patients with elevated native T1, and similar story here with patients with elevated ECV. Here's a patient with suspected infiltrative cardiomyopathy. There's a moderate-sized pericardial effusion and small bilateral pleural effusions. The patient clearly has biventricular systolic dysfunction. And on the look locker or T1 inversion recovery scout, we can see the myocardium goes black before the blood pool, so altered gadolinium contrast kinetics. The magnitude images are not too abnormal. There's perhaps something going on here, or maybe we've just got the wrong TI time. The clue is always to look at the PSIR, which shows diffuse abnormality. And T1 maps really clinch this with diffusely abnormal T1s, all orange over here, and orange to red ECV, which honestly I've never seen one this bad. The native T1 values are markedly elevated, going up to almost 1200, our upper limits being 1050, and ECV going up to 75, and our upper limits only up to 33. And the patient had confirmed high free light chains in their bloodstream. So we can confidently diagnose cardiac amyloidosis. And lastly, an ECV more than 45 is an independent adverse prognostic indicator in cardiac amyloidosis. Back at a time when we didn't used to give contrast to hemodialysis patients, here's someone with a history of systemic amyloidosis in whom we confirmed cardiac involvement with this elevated native T1. Let's look at some other applications. Here's a 63-year-old male with concentric LVH, normal LV cavity size and systolic function, but markedly elevated LV mass index. They have a small volume of non-ischemic scar in the infralateral wall, as you can see here. And on tissue mapping, we have our diagnosis of Anderson-Fabry disease with diffuse native T1 reduction and normal ECV. So we can rule in or rule out Anderson-Fabry disease in hypertrophic heart diseases. The problem, some of you may be thinking, why don't we just look at the concentric hypertrophy and infralateral scar and call it Fabry's? Well, the problem is that in every large HCM cohort, there are always a few misdiagnosed Fabry's cases. So you may be looking at something and think that it is actually hypertrophic cardiomyopathy, this asymmetric hypertrophy patient here, and this one here with apical hypertrophy and apical scar. But in fact, these two patients are actually genetically proven Fabry's cases with an unusual pattern of hypertrophy and more apical scar than you'd see in most Fabry's patients. Also, there are always Fabry's patients with pure cardiac Fabry's and with very little or no manifestations in the rest of their body. It gets more complicated. Here's females, as we know, manifest less scar and have less manifestations of Fabry's disease. And here's a 79-year-old female with hypertension, and it's so easy to attribute the sigmoid septum to their hypertension and call this non-ischemic scar in the infralateral wall as maybe a sequelae of previous myocarditis. But in fact, this patient has Fabry's disease, and she had a pathogenic mutation. And on tissue mapping, we can see that she has significantly lower T1 values in the anterior wall. It gets even more complicated because not only can Fabry's mimic HCM, but we now know that there is a condition that can mimic Fabry's disease. So patients with SLE or lupus are treated with antimalarials like chloroquine or hydroxychloroquine. And although initially thought to be rare, they can develop a cardiomyopathy likely resulting from the antimalarial's reversible ability to inhibit lysosomal enzymatic activity, including alpha-galactosidase A, thereby inducing a lysosomal disease resulting in accumulation of glycosphingolipids very similar to Fabry's disease. T1 values go down with increasing duration of antimalarial therapy, and then if the patient develops antimalarial-induced cardiomyopathy, their T1 and T2 start to go up. If, however, the patient develops lupus myocarditis, T1 and T2 are very high. There's yet another mimic. This is a case report from last year. in 2025 with a patient, 59-year-old homozygous for SMPD1 mutations, and they had low native T1 values because Niemann-Pick disease is a lysosomal storage disorder and leads to deficient acids, sphingomyelinase activity, and lipid accumulation in various organs, including the heart. In HCM cases, we use T1 mapping and ECV to assess for background myocardial fibrosis, as illustrated in this case with anterior hinge point predominant scar. We can see that there is T1 and ECV elevation even in areas not affected by LGE, for example, in the interventricular septum. Some researchers have demonstrated that native T1 values in non-hypertrophied segments are significantly higher in HCM than in hypertensive heart disease. This is a 44-year-old female with a pathogenic beta-myosin heavy chain mutation inherited from a father and reverse septal curvature subtype HCM. You can see that she has a high signal intensity LGE, and you can see corresponding higher elevation of native T1 and ECV in these regions. On Holter, she had runs of NSVT. Some researchers suggest a link between edema in HCM and arrhythmia. And you can see in this patient, not only does she have the T1 and ECV elevation, but there's also edema in the affected regions. This is a more interesting case, a 30-year-old male with an out-of-hospital cardiac arrest that was fortunately shocked back into sinus rhythm, regained spontaneous circulation, and on ECG, they had prolonged QT. We can see that there is not only late gadolinium enhancement, but also high native T1 and ECV, and also edema with a T2 relaxation value of 65 milliseconds, upper limits being 58. Here's a patient, an 18-year-old female who had a cardiac arrest in a train station. She was subsequently discovered to have reverse septal curvature HCM with extreme hypertrophy, which is a risk factor for sudden cardiac death. She also had LVO2 at rest, another risk factor, and 15% LV scar, also another risk factor for sudden cardiac death. We call that she likely had recent intraseptal infarct with intramyocardial hemorrhage, because as you can see here, there's low signal within the enhancing region on these post-contrast cines. And we can see that here as well, the late gadolinium enhancement. And within there, we can see a low signal area. And that is because she's had a MINOCA, so a myocardial infarct with normal coronary arteries because of her HCM. On the tissue maps, we can see that there's low native T1 over here because the iron has leaked out and is reducing her native T1. We can also follow up disease with T1 maps to monitor response to therapy, as we did in this patient with multiple myeloma on chemotherapy. We can also watch to see improvement in patients who've had cardiac toxicity. This patient was given a break from their chemotherapy because their LV function was declining, and we can see if we go back to it, the elevated native T1s and ECVs, and the follow-up study performed 6 weeks later after a break from chemotherapy. T1s have normalized, ECVs are normalizing, and the patients regained their normal biventricular size and systolic function. Here's a 57-year-old male who presented with DCM of unclear etiology, which occurred after their first COVID-19 vaccination. We can see elevated native T1, normal ECV, mildly elevated ECV in the basal septum. They had biventricular dilation and systolic dysfunction, as well as moderate functional mitral regurgitation of 38%. There's no edema. We can see that on the follow-up study, after 17 months of remodeling therapy, their biventricular size has returned normal, RV ejection fraction is normal, their left ventricular ejection fraction is now 38%, and the functional MR has resolved. Importantly, on the tissue maps, we can see that these have all normalized as well. Here's a 56-year-old female with a non-ischemic cardiomyopathy. She unfortunately stopped all her heart failure medication due to a misunderstanding at her previous clinic visit, and now she has a mildly dilated LV with moderate systolic dysfunction. We can see elevated native T1s here. ECVs are normal. On the follow-up study, the T1s have normalized or are normalizing, and the ECV remains static, as well as the T2. And after recommencing her medication 11 months later, we can see not only the tissue mapping has improved, but also the LV ejection fraction. Here's a patient with sudden onset severe chest pain and elevated troponins. normal coronary arteries on angio. The patient, as you can see here, has the dilation or hypokinesia to akinesia of the apical segments. So tachycerebral cardiomyopathy. And on this patient, we can see on the late gadolinium enhancements, we can images, we can see that there is increased signal towards the apex, whereas the base is black, the apex is gray, and you can see that going from base to apex again. On tissue mapping, we can see elevated native T1s, particularly with the gradient going towards the apex, and the same is also true on the ECV map. Here's the T2 map showing elevated T2 in the apex. On the follow-up study done 4 months later, we can see that all this has normalized. And so we can say that we can use tissue mapping to perform quantitative assessment and follow-up after treatment. Just a quick aside, here's a patient with focal Takotsubo, and it can occur very focally and not at the apex as well. And you can see here a focal dyskinesia in the basal anteroseptum, but no infarct, just that mild kind of intermediate signal intensity late gadolinium enhancement. On mapping, however, it's very obvious that there is an abnormality with elevated T2 and T1, as well as borderline ECV. Initially, when you start reporting tissue mapping, you will not have your any local ranges. And so we gathered information and also compared the numbers we were getting to the published ranges based on our magnet and sequence. The SCMR recommends that you create local normal ranges, and from that, you'll be able to figure out whether something is normal or abnormal. Um, the range of normal pre and post contrast T1 relaxation values is affected by the components of the scheme that you have in your practice, and that scheme is a factor of scanner type, field strength, pulse sequence, cardiac phase, region measured, the type of coil, specific contrast agent that you use for post-contrast T1 maps, volume of contrast, time of acquisition of post-contrast images, etc. Therefore, the absolute T1 values can only be directly compared with site-specific normal ranges made up of scans performed using the same scheme. So initially, we started comparing, as I said before, to published ranges, and then we saved our normals from our own local studies to create our local normal ranges. And once we had these, we were able to report whether our T1 values were normal or abnormal. In rarer cases like masses and so on, we are continually acquiring data, and we have a little database locally to determine to see what experience we've had with these masses in the past. Here's a patient with a sarcoma, see positive perfusion and abnormalities on the tissue maps. Here's a patient with a pericardial lymphangioma. Sometimes abnormalities are better seen on cine imaging and even the raw T1 images rather than the tissue maps on which they may be absent, like that myxoma. We use them on mediastinal masses as well because it gives us an objective ability to identify fat, for example, in this teratoma. Some have asked, why do ECV at all? Well, for 3 breath holes and a CBC, you get quantitative late gadolinium enhancement of sorts, mass characterization, further characterization in cardiomyopathies to help you distinguish non-ischemic cardiomyopathy from amyloid potentially, an objective way to confirm abnormal late gadolinium enhancement, possible prognostic indicator in amyloidosis, and possible early detection of amyloid despite normal native T1 values. This is a patient with an acute LAD infarct. If we focus on the core of the infarct where the white arrow is pointing, we can see the ECV drop from 55 down to 49 at the 3-month follow-up, along with resolution of the edema. We go back, we can see edema here, and then the edema has resolved. Outside of the core of the infarct, that's the yellow arrow, it's always difficult to be certain about the exact quantity of the area at risk because edema increases extracellular space, and this allows gadolinium uptake. But we can see that in the area indicated by the yellow arrow, there is some late gadolinium enhancement, and the ECV is mildly elevated at 32%. But at the 3-month follow-up, ECV has normalized and the edema has also resolved. I'm not suggesting that this is what we should do for all cases, but the ability of ECV to provide a more quantitative look at what we regularly see on late gadolinium enhancement is interesting in that it is able to detect, confirm, and follow up many more shades of gray than we were previously able to in simple and also more complex pathologies. This was yeah. So we suspected that there was involvement of the epicardial fat in this patient on late gadolinium enhancement, but we were able to also tease it out a bit further on T1 mapping and ECV. Here's a patient with a myxoma that's hard to see. It's easier to see in the raw images or in no lookup table mode than it is to see on the color maps that we have. You can see it here. But ECV managed to show the abnormality. So we can confirm enhancement in small or subtle lesions. Here's a concept that we learned over time that for a similar T1 value, DCMs have a lower ECV than you would get in amyloidosis. So here are two cases. One is the DCM and one is the senile amyloid. We can see that the native T1 for both these pathologies is relatively similar, but the ECV for these pathologies are significantly different. For DCM, we have a mildly elevated ECV in the basal antroseptum, and for amyloid, there's diffuse ECV elevation. Here's an 82-year-old male with HFpEF and a clinical pyrophosphate scan that was referred to us to rule out ATTR amyloidosis. T1 values were actually normal, but our ECV was markedly abnormal. And we thought, oh, something's gone wrong here. The tech has potentially scanned the post-contrast T1 maps too early. So we actually recalled the patient and we got basically the same result with a T1 value of 1058 and an ECV that's elevated at 41. Remember, our upper limits are 31, right? So what this is likely early cardiac amyloidosis. And then there's papers to suggest that this is the case, that ECV is more sensitive than T1 mapping in some cases. Here's a 29-year-old female with a new dilated cardiomyopathy diagnosis referred to us to rule out significant late gadolinium enhancement. She traveled to South America and one of the clinical concerns was Chagas disease. But a blood film was negative for Chagas, and then she subsequently disclosed that she had consumed significant alcohol while she was on her trip, as well as cocaine and other recreational drugs. She had a mildly dilated LV with mild to moderate systolic dysfunction, and on late gadolinium enhancement, although there's not, and on late gadolinium enhancement, there's nothing much to see. Certainly nothing focal. In the old days, you get this, and maybe you get a T2 weighted black blood, and then be humming and hawing about whether there was or wasn't myocardial edema. Here, fortunately, we have T2 mapping, and as you can see, there's widespread edema with a septal to lateral gradient. And there's diffuse abnormality on T1 and ECV. And so with tissue mapping, you're able to confirm diffuse and uniform abnormalities. Here's someone with pure apical HCM. And as we get to the apex, we can see that the patient has a thickened myocardium, and the short axis T1 maps are essentially normal. But when we go to the vertical long axis T1 map that I mentioned before, we can see the ECV is elevated at the true apex. And we can confirm subtle late gadolinium enhancement. And just as I mentioned before, we always get a vertical long axis map in our HCM protocol. In complex cases like this RV sarcoma, we find it can add more objective measures to what we see. ECV can turn a fairly black and white image, like we have in the top left corner, into something more diagnostic in the bottom right image, where the thrombus is black, and the dark is black and dark blue globs, and green is the tumor, and the remaining RV cavity is the yellow and red channels that we see. Turning back to T1 for a moment, the thrombi we identified on ECV with the darker colors and low ECV values can be reanalyzed on T1 to provide us with information regarding the age of these thrombi. In this case, the higher T1 values we see mean these thrombi are older. Here's another chronic thrombus. And here's a paper demonstrating that older thrombi have higher T1 values. This sub-study from the EMPA-HEART CardioLink 6 trial data suggests that empagliflozin modifies diffuse ECV expansion, but not focal scar. So here's someone on EMPA, and we can see that although they have normal T1 values, their ECV is actually lower than our normal range. Technologists. So I usually provide positive feedback directly, and I CC the operations leader, and it's an attaboy, well done. Negative feedback is usually fed to the operations leader, who then takes it up with the techs. I do this because she also needs to have an overview as to what is going on in her department, and if there are certain things that maybe need kind of additional teaching or clarification with the CMR team. Um, when we want to make changes, we seek guidance from the operations leader on the best time to incorporate those changes and be patient. It's a long journey, and you make slow incremental improvements over time. A yearly QA session is good, and, sponsored maybe by one of the companies with lunch. And I save up my feedback emails so that we can run those and look at potential issues with scanning. Um, in terms of acquisition, make sure it's the right sequence. We were a few months in before we realized that our post-contrast mollies were basically the native molly rerun after contrast, but in fact, Philips has separate two different sequences for native and post-contrast. So something we weren't aware of and subsequently incorporated. Planning. So planning is a thing that comes up again and again. The techs, send us cases where, they've bunched all the slices into the middle of the left ventricle, or they've caught the basal slices caught the left ventricular outflow tract, or maybe even the annulus. And so I have a document with how to make T1 and T2 maps, a Word document that I have ready, or a PDF. And whenever I get one of these cases, and it may be our tech scan everything, right, head to toe. And so they're not cardiac specialists, so they may need this additional bit of a bit of help. And how we acquire our T1 and T2 maps, usually if we get the 3 slices, is we start off with 5 slices, one touching the annulus, one at the apex, and then we reduce down to 3. For the T2 maps for myocarditis, we will take the 7 slices and spread them out to cover the entire left ventricle. Slice positioning. So if you look at the blue line, you can see there's the pre-contrast map, and here's the post-contrast map. And there's been a slight change in angulation, and that's enough to prevent you from using this slice to generate a polar map, for example. If there's a difference between the voxel sizes between these two scans, the pre and the post, again, it will stop you from conducting ECV analysis, and you have to revert to a calculator to do that. Timing is important. You got to run your native T1 and T2 maps before contrast. That seems obvious, but again, techs sometimes fall foul of this. And there is a fixed time for your post-contrast T1 maps. At our institution, it's at 15 minutes. Here you can see a patient with normal native T1 and markedly elevated ECV. So are we dealing with amyloidosis? So when we interrogated this case some more, we were able to figure out that it was in fact that the techs are very good at trying to save time, and so they acquired their post-contrast T1 maps early at 8 minutes instead of 15 minutes, and the ECV calculation was therefore high. If you get frequency artifacts like we got here in this case, and they're not corrected, they will translate over to the tissue maps and mess those up. Acute myositis. Oh, sorry. We'll come on to acute myositis in a second. This is a case with an elevated ECV. Is this diffuse fibrosis despite a normal T1 value? Or did we just forget to update our hematocrit? So there you can see a bit of a diastolic wobble here. And diastole is when we acquire our tissue maps. And if there's a significant wobble, oftentimes in the mid LV, this can affect the fused maps that you get, for example, from Philips, because Philips just takes all the Molly images, the raw Molly images, and fuses them together to create your final image. And so we just have to go back into the Molly images and create regions of interest that track with that motion to get the septal ROI or the septal T1 value. Here's a case of pseudonormalization. So while on the face of it, the anterior and anteroseptal walls look about normal and the rest looks abnormal, everything is abnormal. The anterior and anteroseptal walls have abnormally low T1 because they are a mix of infarct and fatty metaplasia of scar, and there's non-ischemic scar elsewhere with high T1. Together, these cancel each other out, and you have a normal global T1 of 980 milliseconds. Without color lookup tables, you could wrongly conclude that the global T1 or maybe a septal ROI was normal. This is an interesting case with both T1 and T2 pseudonormalization in acute myocardial infarct. In this case, there's pseudonormalization of the global T1 because of the low T1 values of intramyocardial hemorrhage cancelled out by high native T1 values from the acute MI. Also look at the post-contrast maps and ECV demonstrating the microvascular obstruction. On T2, there is pseudonormalization of the area of intramyocardial hemorrhage where low native T2 values due to the iron are cancelling out the high T2 values from the acute infarct. The blue of the intramyocardial hemorrhage is in the normal T2 range as the remote myocardium. This is a 29-year-old female with mixed connective tissue disease and overlap autoimmune condition with inflammatory myositis, lupus, and scleroderma, who presented with troponin elevation in whom the clinicians wanted to rule out myocarditis. There's diffuse myocardial edema. As you can see by the orange T1 polar map, there's diffuse T1 elevation and the ECV is globally high, but the late gadolinium enhancement images are washed out, and the post-contrast T1 values are abnormally high. This is because the majority of the double gadolinium dose has been sucked out of the blood pool by something else, namely the myositis. Therefore, ECV calculations are unreliable. 2 days later, not much has changed. At this 4-month follow-up, we can see that's resolution of the diffuse edema and near normal T1 and ECV. So learning for that, we now essentially do non-contrast imaging in cases like this in acute myositis, patients in whom the clinicians want to rule out myocarditis. This is diffuse T1 elevation and patchy multifocal myocardial edema. And this is the follow-up demonstrating resolution of the edema 4 months later and normalization of T1 mapping and ECV. This is a 19-year-old male post VFib arrest while playing basketball. Here is native T1 of 1073, which is at the upper limits of normal. And the post-contrast is T1 has a T1 of 672, which is unusually high for a post-contrast T1. The majority of the GAD has been soaked up by extracardiac pathology, in this case bilateral aspiration pneumonia, because the ECV calculation depends on the post-contrast imaging, and because that is skewed by gadolinium being soaked up by the pneumonia, the ECV is unreliable. So we finally done it. You've robbed the bank. You bought the sequences, you taught your text, you shortened the scan length, you figured out your normal ranges, triage your requisitions, deployed tissue mapping on the majority of your clinical protocols, and you're mapping. Fantastic. But now, like the foolish miller's daughter in Rumpelstiltskin, we are locked in the tower surrounded by bales of hay that we have to spin into gold by morning. And every scan takes longer than before to post-process and report because now we have tissue mapping to do on every case. But take heart, people. Keep calm and contour on because AI is coming to save the day. Thank you for your attention, and thank you for our dedicated technologists who are responsible for all the images we've seen here today. Me hearties, thanks for listening to me talk. Don't you forget to think like pirates.